My name is Jordana Fein with the Retina Group of Washington, and I'm going to be talking to you today about the clinical trial results from the QUASAR clinical trial. So QUASAR was a multi-center randomized control study evaluating the efficacy and safety of 8 milligram aflibercept in patients with retinal vein occlusion and associated macular edema. The control arm was 2 milligram aflibercept given monthly, and 8 milligram aflibercept was given initially either every monthly for 3 months or monthly for 5 months, and then extended after that. So primary endpoint of the QUASAR clinical trial was at 36 weeks. And this was a non-inferiority trial looking at whether or not 2 milligrams and 8 milligrams were equivalent. And it met its primary endpoint, where 8 milligrams was non-inferior to 2 milligrams. However, there was significantly less injections given over that time interval. We are talking during this meeting about the 64-week end results. And so at 64 weeks, we looked at the number of active injections from baseline to week 64, and also continued to look at things like safety, durability, and total number of injections given over that time point. So that's a great question. It's worth stepping back and really thinking about why retinal vein occlusion is different than things like neovascular AMD or diabetic macular edema. So both diabetic edema and AMD, they're more chronic conditions where we have this slow release of VEGF over time. RVO is a completely different, acute ischemic condition where you have an immediate, very high VEGF load in the vitreous and into the retina. And so RVO, if we look back at the old clinical trials, Bravo, Cruz, the initial trials that led to approval of these anti-VEGF agents, patients were treated monthly for 6 months and not able to extend out initially at all. And so this really is the first clinical trial where we're looking at extension of patients with RVO, especially who have a high VEGF load, and seeing if we can see the same level of efficacy, but hopefully with fewer injections, which is what we found in QUASAR. Yeah, so we think about this also with our DME patients, but every time a patient has to come in for an intravitreal injection or just an office visit, we're talking about a day off work, potentially having a driver come with them. And so there's, productivity loss. And I would say in these RVO patients who are younger, they often are still likely to be working or more likely to be working. And so, having to come in monthly for, clinic visit and an intravitreal injection is definitely a significant burden. This was looked at the 64-week mark, and there was no difference, when we look at all of our safety data between the 8 milligram arm and the 2 milligram arm in terms of safety profile. So we can rest assured that the 8 milligram dosing is just as safe as the 2 milligram dose, but with significantly less treatment burden. Yeah, so that's a great question. I can just tell you from my own experience, I have found personally that aflibercept tends to work better for my patients with RVO versus faricimab. But I think it's great to have options, and all of these patients are different. There are certainly some patients that respond better for whatever reason to one agent versus another. I don't yet have a good sense, like a good biomarker when I look at a patient's initial OCT or vision to say, I'd rather use this second generation anti-VEGF versus another. But I can tell you that, in my practice, the aflibercept 8 milligram would be my, go-to injection to start with. Yeah, so I think that's really where this, QUASAR data really helps us and shines because, to date, as we were discussing in the clinical trials or the older clinical trials, patients were dosed monthly for 6 months. And if we look at data from things like Copernicus or, other older data, once patients stopped having frequent treatments, actually we saw that the vision declined over time. And so with QUASAR, I think we can we have a paradigm shift where we're able to do monthly injections for 3 months or monthly injections for 5 months, and then immediately extend to 8 weeks and beyond. And so I would just highlight with this extension, and I don't think we talked about this yet. We're seeing basically 80% of patients at the end of QUASAR in the high dose 8 milligram arm being able to extend out past 12 weeks, and even 40% of patients who were in the 8 milligram monthly for 3 months were able to extend out past 20 weeks. And again, in these extension patients, we did not see any evidence of, worsening visual acuity or worsening of their OCT. So when I discuss now with a patient who has RVO, I'm saying we're going to inject you monthly for the first 3 to 5 months, depending on, how severe their disease is. And then I'm hoping to get you out to every 8 weeks or even longer. And I expect that, the vast majority of these patients I'll be able to treat every 12 weeks, by the 64-week mark. So, I would say that, we have had great treatment. We're very lucky to have had anti-VEGFs available to us. I think most retina doctors are very comfortable using 2 milligrams. Many would say that's sort of the gold standard that they've been using to treat, for the last, 10 to 20 years. I think that, the time is now to try to utilize some of these, longer duration agents. Because the safety profile is, the same as 2 milligrams, and you have the opportunity to treat your patients less frequently. So yeah, that's a great question. We definitely utilize some technology in our practice. We personally use virtual scribes. But virtual scribe where I have a person in my ear and they're running the Zoom and actually, inputting everything I say into the chart. That's not AI though, that's an actual real human. We still find that to be, a better scribe for us. I know there's been some people who've been trying using more like scribes who are actually AI scribes. We haven't made that jump or leap yet. Just because, the documentation and the billing and coding is, so important to what we do. My guess is those technologies will be there at some point in the next few years. I personally haven't, utilized them or seen them yet. I think that we will have better AI models for things like modeling geographic atrophy. Right now we're manually trying to, measure the amount of atrophy in a patient and follow that over time. There are models that have been have been created, but they're not commercially available. So I think a lot of the AI stuff is amazing. I don't think most of it is really, ready for prime time or, usable in the clinic at the moment, at least in my experience.